Well, welcome back to Chapter 30 and Part 2 of Trauma Systems and Mechanism of Injury. We're going to pick up here in Part 2 talking about blast injuries and really just kind of the ins and outs and a lot of the details that are related to those and why we see the types of injuries that we do see when someone has been near an explosion of some sort. So, when we talk about blast injuries, we look at different types or different levels of blast injuries. And the first one we're going to talk about is the primary blast injuries. These are caused by the pressure wave that's generated by the explosion. When that explosion happens, it forces all of those air molecules outward, and it creates this wave of pressure from these molecules being forced away from the center of the blast. So the pressure concentration comes from that rapid displacement, as well as the heat at the center of the blast. Organs most commonly affected are going to include lungs, eardrums, and other compressible organs, so those organs that have hollow spaces in them. Being close to the blast's origin significantly increases the risk of severe injury and, of course, death. The closer you are to it, the more likely you are to suffer significant injuries and death. Secondary injuries, on the other hand, occur when the patient is hit by different types of flying debris. The shock wave creates a blast of wind that pushes air molecules outward, and it can pick up these particles and pieces of debris, as well as it could be components of the explosion itself that are pushed outwards as well. Flying debris can cause both blunt trauma as well as penetrating trauma. It just all depends on the size of the object and its velocity or speed that it's traveling will determine whether it's going to be a blunt or a penetrating injury. Tertiary blast injuries happen when a person is thrown by the explosion or the blast into other solid objects, whether that's the ground, a building, or a wall, or something like that. And then ground shock refers to injuries caused when the body hits the ground after being displaced. So tertiary injuries, maybe you're thrown into a wall and then you get ground shock when you bounce off the ground. Miscellaneous types of blast injuries that we might see typically result from other events associated with an explosion. These injuries could include burns, it may be respiratory damage, crush injuries from entrapments, and those kinds of things that may follow that is a result of the explosion, but not directly caused by the explosion. And then we have quinary blast injuries that are caused by biological, chemical, or radioactive contaminants added to a conventional explosion. So there may be other elements or other things added to that device that causes other injuries or additional injuries. These injuries are often associated with what we call a dirty bomb, where they've loaded that bomb down with something else. This shows kind of gives you an idea of what that blast radius and blast injuries are going to look like. Of course, if you've got a building on one side of this blast, it would protect things on the opposite side of that building. However, it could actually kind of shape the blast into a particular direction, which may actually increase the damage that it causes. When a substance detonates, it is rapidly converted into large volumes of gas under extremely high pressure. Propellants are explosives that release energy relatively slowly compared to high explosives. So when we're talking about a propellant, something along the lines of maybe a can of spray paint would be considered something that contains a propellant. It can't explode, but it does it at a slower rate compared to, say, TNT, or cordite, or something like that. Maybe not cordite, but some other explosive materials. I think I was thinking of plastic explosives. Those are going to explode at a much faster, they're much higher velocity. The blast front is the leading edge of the explosive's pressure wave. And then the positive wave pulse is the phase when the pressure exceeds atmospheric levels. So once it gets over that, 32 pounds per square foot or square inch. Once it exceeds that, then that is considered a positive wave pulse because it exceeds atmospheric pressure. And then we can have shock waves from these high explosive that can have brissonance, which means they can shatter structures and tissues along the way. The shock wave and the pressure wave from these explosions can be so great. They can separate limbs from the body. They can, obliterate structures, into, tiny pieces because the pressure and the wave that's coming through is so great. Of course, the extent of tissue damage is going to have a lot of factors. It's going to depend on a lot of factors. Of course, the pressure spike and the magnitude is going to have an impact on that, as well as the duration, how long that pressure spike and pressure wave was. The negative pulse wave pulse occurs when the displaced air returns, creating pressure below atmospheric levels. So it pushes all that air out and it creates a vacuum once that air is pushed out, and eventually that air is going to come back. It's going to return back in there. So air is going to be pushed out, then you have, and what leaves a negative pressure, and then it's going to return. This negative phase can actually produce some really high velocity winds because as those air molecules are trying to re-enter that space, it does it quickly because it's trying to refill it. It's just the natural way of things. The speed, duration, and pressure of a blast shock wave are influenced by several factors. Of course, the main one being is the size of the explosive charge. Larger explosions produce faster shock waves that last much longer. The nature of the surrounding structures or the surrounding medium, pressure waves travel faster and are more powerful in water. One wouldn't think so, but tsunamis and all those kinds of things, they're able to propagate that pressure wave much better. The distance from the explosion, shock waves are of course going to slow down the longer or farther they travel away from the center of the explosion. Of course, the larger the explosion is or the more powerful it is, the farther the shock wave is going to travel. But eventually it's going to reach the distance that it can travel to, and it's going to begin to dissipate or to slow down. As I mentioned before, you can have some reflecting surfaces, such as some solid surfaces that can actually reflect the pressure wave, and it can even multiply its force by several times. So if it's placed in a particular way, it can actually shape the blast a direction that can cause a lot more damage in that particular direction. Explosions are more destructive in enclosed spaces because the pressure wave actually bounces around inside of the room. Limiting space reduces the dissipation of that energy. And of course, the toxic gases and smoke will accumulate in that space. And then shock waves are going to intensify when they encounter those solid surfaces. So it's going to magnify them as they're bouncing around in there. Air-filled organs are particularly vulnerable to blast pressure changes, including the middle ear, the heart, the lungs, and major blood vessels, and even the gastrointestinal tract. Tissue junctions where densities differ and exposed tissue are also prone to injury. So where some tissues kind of connect together we might see a greater likelihood of some injuries there. Of course, the ear is going to be the most sensitive organ when it comes to blast injuries, and the tympanic membrane will often rupture, and patients may experience a ringing, ear pain, hearing loss, and even visible blood coming from their ear canals. Primary pulmonary blast injuries can cause contusions and hemorrhages in the lungs. Patients may experience chest tightness, pain, rapid breathing, or other signs of respiratory distress. Subcutaneous emphysema over the chest may indicate an underlying pneumothorax as well. Pulmonary edema can develop. If lung injury is suspected, of course, we're going to administer oxygen carefully, avoiding the use of positive pressure delivery or systems that deliver pressure, positive pressure, such as ventilators and those kinds of things, as much as possible because we don't want to contribute further to the injuries. IV fluids may be poorly tolerated in patients with a pulmonary injury, so we need to keep that in mind and not just drown them in IV fluids. Arterial air embolisms can occur when the alveoli is disrupted and air managed to enter the pulmonary circulation. Even small air bubbles can reach the coronary arteries, causing myocardial injury. Air embolisms may produce visual disturbances, behavioral changes, altered consciousness, and even other neurological signs may be present whenever a patient has an air embolism. Solid organs are a little better protected from the primary blast waves, but they can be injured by flying debris or displacement of the body. Neurological injuries and head trauma are the leading cause of death in blast victims. Things like a subarachnoid, subdural hematomas are really often seen with blast injuries. And then we might see some neurological deficits, permanent or temporary deficits that may result from concussions, intracranial bleeding, or air embolisms. Extremity injuries, including traumatic amputations, are common in blast incidents, but they are still, very survivable. We have many military veterans that have lost all 4 limbs in a blast and are still with us today. So when we're assessing and managing blast injuries, we want to make sure that we anticipate significant trauma and multiple patients at the scene. For intentional explosions, check for secondary devices before approaching. And when I say check for secondary devices, that doesn't mean you checking for them. Make sure that they have cleared the area and determined that it is safe and there's no secondary devices. If the scene is safe, of course, evacuate. If it's unsafe, we're not going to go in, we're going to stay away, and we're going to wait until it's confirmed safe. Evaluate the scene for other potential hazards along the way. Remember, the explosion is going to disrupt a lot of things, and it can create a whole host of other hazards that could be problematic for us as we try to enter that scene. Along the way, make sure that we keep a close eye on the patient's breathing rate and their breath sounds. Quickly examine for open and closed wounds and address any life-threatening injuries that you find. Get a good baseline pulse oximetry reading and monitor the pulse ox regularly. High flow supplemental oxygen. Even if your PCO2 readings are high, go ahead and give them high flow oxygen. Do not assume the absence of an abdominal injury even if there are no obvious signs, because they can mask them well. A lot of bleeding can occur into the peritoneal spaces and all that, and you might not be aware of an abdominal issue until it's almost too late. If the patient reports pain, use the OPQRST mnemonic to assess it. Ear injuries may cause dizziness and vomiting, which can compromise the airway. And of course, we want to manage any impaled objects according to established guidelines, especially if they're in the soft tissues of the neck and face. We're going to follow those trauma protocols for how to manage those types of things when we come across them. Of course, managing a trauma scene, we'll move on into scene size up. When we're managing that trauma scene, it's going to require attention to external factors more than your typical medical emergency call is going to. Your observations are going to provide some essential information that we can pass along to the hospital staff. And most trauma injuries cannot be fully stabilized on scene. It's really important for us to realize that the patient may actually become less stable the longer we spend at the scene, and we need to be cautious not to use up what little valuable time they have left. So when it comes to scene size up, always use appropriate personal protective equipment, including gloves, protective eyewear, masks, and other PPE, based on the mechanism of injury that we're dealing with at that particular time. You want to make sure that you anticipate any potential hazards while you're en route to the scene, but don't get too tunneled in on what you're being reported to you of what is going on. Once you arrive on scene, you may visualize something different, so don't get your heart too set on what exactly how or what you're going to see. Don't be too anticipatory. Continuously assess the environment, both initially and throughout your response, because things can change, things can deteriorate. Determine the number of patients and whether additional medical resources are needed. And of course, gather that key information. For falls, you're going to note the height and type of surface that the patient landed on. And for motor vehicle crashes, observe the extent of vehicle intrusion, vehicle speed, and whether the patient was ejected. These are some of the few times that utilizing your cell phone or something like that to snap a couple of pictures so that you can show it to the staff in the ER, not so you can post something on Facebook, but so that you can pass it along to the trauma team that's going to be caring for the patients. And that way they have a really good idea of what types of injuries to look for, anticipate, or suspect. Form a general impression of the patient, but avoid making major care decisions based solely on your first impressions. Keep the mechanism of injury in mind as you approach and consider if spinal motion restriction is going to be needed. Assess the patient's responsiveness using AVPU. Awake and alert, responsive to verbal, responsive to pain, or even unresponsive is going to be a really helpful indicator as you move forward in your patient assessment. Follow the ABC sequence where we're going to look for exsanguinating issues, and then we're going to go to our regular ABCs. Address any life-threatening injuries or significant external bleeding immediately. If CPR is not required, proceed to assessing the airway. If the patient is unresponsive, have your partner open the airway using a jaw thrust remover. Consider placing an oral or a naropharyngeal airway as needed. But of course, you're going to make sure that you need to check for obvious oral and facial trauma that could obstruct the airway or would be a contraindication for using a nasopharyngeal airway. Remove any foreign objects and suction blood or vomitus out of the airway as necessary. If a foreign object is suspected to be causing a blockage, use the appropriate manual airway clearing technique as needed, but you may need to move on to a more advanced management style of the airway. Once you get the airway clear, assess the patient's breathing. If they're not breathing, go ahead and ventilate them via bag valve mask and consider a more advanced airway. If the patient is breathing, evaluate the rate and quality of the respirations and their ability to speak. Observe the patient's skin color, watch for the chest wall movement during respiration, and if there's a sucking chest wound present, immediately seal the wound. But don't forget to look for, if you're suspecting a gunshot wound, don't forget to look for exit wounds. Assessing the thorax and neck for a deviated trachea and a tension pneumothorax, crepitus, broken ribs, fractured sternum, or other issues that could impair breathing. Remember, we're looking for any kind of breathing issues that's associated with this trauma. Determine the most effective way to support the patient's respirations from that point forward. Evaluate the patient's circulation by assessing the rate and quality of the pulse. If they don't have a pulse, start CPR. Observe skin signs including color, temperature, and condition, because these are really good indicators of their circulatory status. Assess the patient's neurological status by using the GCS score. Check pupil size, equality, reactivity to light. Evaluate the pulse, motor function, and sensation in all extremities, and then be sure to expose the patient as needed to conduct a thorough examination. Quickly scan for life-threatening conditions and manage them as they are identified, and don't delay getting those taken care of. Patients requiring immediate transport includes those with an altered mental status, airway and breathing difficulties, multi-system traumas, and severely compromised circulatory patients. If immediate transport is necessary, continue assessing the patient while en route to the trauma center. Be sure to limit your on-scene time to 10 minutes or less, known as the platinum 10 minutes, because everything over 10 minutes you're stealing away from their golden hour, and we need to make sure that we get them in that, in the surgery center if they need surgery inside of that golden hour. So every minute we spend every additional minute past 10 that we spend on the scene with a critical patient, we're stealing precious time. Obtain a sample history from the patient, at least as best you can. Collect a medical history as soon as possible. In case the patient's consciousness changes, If the patient is unresponsive, you can gather that information from bystanders or family, potentially. Key information include patient symptoms, allergies, medications, past medical history, last oral intake, and what events led up to this particular incident. Trauma patients are categorized into two main groups: isolated injuries and multi-system trauma. For isolated injuries, it's okay to focus immediately on the primary problem. If they say, I crashed my bike and my leg hurts, I think it's broke, it's okay for us to isolate a little bit more on that problem. We're not ignoring the other body systems, but we can begin to isolate. But for multi-system trauma, where we're finding multiple injuries and multiple things going on, it's important that we identify all the conditions that we can and prioritize them by their severity, and that way we can get our treatment plan in order for the most serious things to the least serious. Consider how each injury or condition may affect the others as well, and then fold in their medical history into that as well and how that might play a role in it. Get a good set of vital signs, because we're going to need a really good baseline set of vitals. Assessment should include pulse, respirations, blood pressure, pulse ox, glucose when appropriate or when possible, cardiac monitoring, automated blood pressure monitoring if it's available. All of those are good steps to take. Most patients with multi-system trauma should receive a thorough physical exam before and during transport. Realize that patients that are in multi-system trauma states oftentimes don't know all of the injuries that they have. They may complain of one or two things or nothing, but realize that they can easily have multiple systems involved in their traumatic event. Conduct the exam systematically to ensure that you don't miss anything along the way. So make sure that you have that systematic approach developed when you go out there and you start taking care of these patients. Head and neck, we're going to palpate and inspect for deformalities, contusions, abrasions, penetrations, burns, tenderness, lacerations, and swelling. This isn't anything new. We talked about all of these things in patient assessment. Look at the nose, mouth, and ears. Reassess the pupil size. Make sure that they're equal and they're reactive to light and they're staying that way. Look for JVD. Consider applying a cervical collar while continuing the assessment if you're suspecting spinal issues. Inspect and palpate the chest wall for injuries. Remember, this is going to be one of the bigger things that we're going to be concerned about, aside from the airway, and making sure that there's no junk, blood, vomit, teeth, or whatever in the airway, but also that the chest wall is intact, at least enough so that they can breathe, and we don't have a breathing issue, a compromise in that area. Look for penetrating wounds and bruises. Listen for breath sounds and heart tones. Palpate the abdomen. Put your hands on the abdomen and palpate that. Check, you can check for pelvic stability, although it isn't super serious to do this. And remember, kind of try to avoid manipulating a pelvis too much, because in a traumatic patient, a lot of blood vessels run right along those bony processes of the pelvis, and jagged edges can cut those arteries and veins. So that's why we don't manipulate the pelvis a whole lot. If we suspect that there's a pelvic injury, we're going to splint that pelvis so we can get it good and stabilized. And of course, then we're going to examine for signs of those less common things, such as incontinence or bleeding in the groin area, or that kind of thing that might be an indication of other types of injuries that might need to be investigated a little more deeply. Palpate each leg from top to bottom, examine them separately, noting any differences that you find from right to left, from one leg to the other. Check both feet for pulses, movement, and sensation. Examine arms in a similar fashion, being sure to check for pulses, movement, and sensation as well in the hands and wrists. And then don't forget to check the back of the patient. Check on the back side of the patient. Inspect and palpate for any kind of back injuries or anything along those lines. And this is especially true if you have any penetrating traumas to the chest that you might suspect as gunshot wounds or high velocity projectiles or something that has penetrated the chest or the abdomen or something like that. You want to see if there's a through and through. Perform another rapid full body scan while en route to the hospital. And of course, repeat the primary survey using the XABC sequence. Recheck vitals every 5 minutes for those critical patients. You can delay it a little bit longer for the less critical or for those isolated injury patients. And then we want to make sure that we review the effectiveness of all of our interventions along the way afterwards and seeing if they're having an effect. They may actually be having an effect, but your patient may be so serious that they're deteriorating as fast as what you've done is improving them. So they're giving the impression that they're staying relatively stable. These are the patients that will crash on you suddenly without warning. And that's why that platinum 10 minutes is really critical for them, and that we get them on the move and get them to a definitive facility that can handle their unique injuries. Notify the receiving hospital as soon as you're able to let them know what you're bringing them so they can prepare the appropriate personnel on their end to handle that patient that you're bringing in. Trauma scoring system. This trauma scoring system we use really helps to determine the severity of injuries in healthcare. There are several different types of systems available, but the trauma score estimates the likelihood of patient survival based on a scale from 1 to 16, with 16 being the best possible score. It does actually consider the Glasgow Coma score into that, and it is useful to have that. Respiratory rate, respiratory expansion, systolic blood pressure, and capillary refill are all those elements to that. So we take the GCS and we assess the patient's level of consciousness, and then scores are assigned for eye-opening, verbal response, and motor response. And this can help predict patient outcomes. It does not reliably predict survival in patients with severe head injuries, though. However, we can use the revised trauma score to give us a little better indicator. This is a physiological scoring system used to assess the severity of a patient's head trauma. This score is heavily weighted to account for severe head injuries, even when other multi-system injuries or major physiological changes are not present. The calculation of the revised trauma score is based on 3 key data points: the patient's GCS score, systolic blood pressure, and the respiratory rate. Pretty simple. This revised trauma score is considered a reliable tool for predicting survival in patients with severe injuries. The score ranges from a high of 12 to a low of 0. And here we see a table that kind of outlines that. You see that top score. If we got a Glasgow of 13 to 15, they get 4 points. Systolic above 84, 4 points. Respiratory rate of 10 to 29, 4 points. So all 3 of those, we get a 12 and they're doing great. But if we get a GCS of 13 to 15, but their blood pressure is, say, 76, or let's say 72, then they're only going to get 2 points there, and their respiratory rate is 6, then they're only going to get 1 there. I'm not sure how you would have that, but you can kind of see how that plays out. And then we would have a patient with a trauma score of 7, which would not be a good score. It's about middle of the road. But you can see how that revised trauma score works. This is going to be most helpful in those head injury patients. And where this is going to be really beneficial, it's not like you're going to do this score one time. You're going to do a few times along the way, as with your GCS as well, especially if your patient's condition is changing along the way. You're going to continue to do another GCS if your patient's condition is changing, and if they have a head injury or potential head injury, you're going to redo the revised trauma score multiple times, and that way you can relay to the staff at the hospital. Initially, I had a revised trauma score of this, and now what you see is what you get. Initially, it was 12. Now we're down to 4. Or something along those lines, and that way they've got a better indicator of how rapidly the patient's condition is changing. When managing trauma, it's critical to perform an accurate assessment and have a strong knowledge of the mechanisms of injury or the mechanics of injury. During patient transport, you should begin with any necessary interventions. Most unresponsive trauma patients will require an advanced airway, which should be placed before transport if at all possible. Other treatments like bandaging, minor wounds, or splinting those fractured extremities should be done en route to the hospital if the patient's condition is critical, and it's not unusual for you to never get to those, for you to never be able to get to the point where you splint a fractured tib fib, unless there is the risk of bleeding or those kinds of things where you have no choice, where there's a problem. But it is entirely possible that you may not get to a fracture, an obvious fracture of an extremity, because the rest of the patient, other areas of the patient's too critical. Most patients in shock should be given oxygen, kept in a supine position if they can be, and transported quickly to a trauma center. When treating patients in shock, you should also consider fluid resuscitation. If the shock is caused by a large fluid shift, a large amount of fluids might be necessary. However, if the shock is due to blood loss, using too much fluid could dilute the patient's blood and raise their blood pressure too high. If shock is caused by vasodilation from a spinal cord injury, you should consider giving medications instead of additional fluids, and be sure to consult with medical direction to see what they feel is the best course of action. When you begin fluid resuscitation, start with volumes that maintain a minimum blood pressure. You don't want to overdo it. You don't want to raise that blood pressure too much and cause more bleeding. Several techniques can be used to treat patients with multi-system trauma. Remember, you can't stabilize these patients in the field, so a team approach should be used to assess and transport them. Critical thinking is very important when you're treating patients with multi-system trauma, because it's essential that you're thinking a few steps ahead of where you're at in your treatment plan. The lethal triad of trauma is a very dangerous cycle that can occur in severely injured patients, consisting of three conditions: hypothermia, coagulopathy, and acidosis. Hypothermia, or low blood temperature, is a serious concern because it contributes to coagulopathy and lowers the patient's survival rate. Coagulopathy is the ability of the blood to clot. This leads to increased blood loss, and if left unchecked, can lead to poor perfusion and death. And then acidosis often occurs with excessive bleeding and the treatments used to compensate for it. If it further complicates the patient's condition, contributing to coagulopathy. So hypothermia and acidosis, if untreated, will lead to coagulopathy, and the body's not going to be able to blood clot, and they will continue to bleed out. To manage this lethal triad, you must aggressively control bleeding, and it is critical to keep your patient warm to prevent hypothermia. You should also minimize the volume of acetic IV fluids that you administer. Monitor end-tidal carbon dioxide and ventilations to help manage acidosis, and consider administering TXA to help control internal bleeding if your protocols allow it. The American College of Surgeons Committee on Trauma and the Centers for Disease Control and Prevention have developed a field triage decision scheme to help you decide which patients need to go to a trauma center. If a patient meets any of the following physiological criteria, they should be taken to the highest level trauma center available. This includes a GCS score of 13 or less, a systolic blood pressure below 90, or a respiratory rate less than 10 or more than 29 breaths per minute. Infants, a respiratory rate of 20 breaths per minute or a need for ventilatory support also meets this criteria as well. If a patient has any of the following anatomical injuries, they should be transported to the highest level of trauma center. These injuries are going to include penetrating trauma to the head, neck, torso, or any extremity proximal to the elbow or knee. Other criteria are chest wall instability or deformity, 2 or more proximal long bone fractures, a crushed or mangled extremity, or an amputation proximal to the wrist or knee. A patient with pelvic fractures, an open or depressed skull fracture, or paralysis should also be taken to the highest level of trauma center. If a patient has a significant mechanism of injury, they should be transported to the closest appropriate trauma center. For adults, this includes falls of more than 20 feet. Children, that's a fall of more than 10 feet or 2 to 3 times their height. A high-risk motor vehicle crash is also a key indicator, especially if there's an intrusion into the passenger compartment, partial or complete ejection from the vehicle, or death of another occupant in the same passenger compartment. Additionally, if the vehicle's telemetry data suggests a high-risk injury, this would also be a red flag. And this telemetry would indicate something, really high G forces that were acted upon, that the person in the vehicle had to endure. Other mechanism of injury criteria include a pedestrian or bicyclist being thrown or run over or hit by a significant impact, and a motorcycle crash at more than 20 miles per hour. If a patient doesn't meet the physiologic, anatomic, or MOI mechanism of injury criteria, you should consider transferring them to an emergency department or lower level trauma center if any of these special considerations are present. These considerations include an age of 55 years or older, systolic blood pressure less than a 110, and a patient older than 65, or a systolic pressure less than 110 in a patient older than 65. I'm sorry, I'm having trouble spitting that out. Any child should be triaged to a pediatric capable trauma center. Other factors that require special considerations are if the patient is pregnant, more than 20 weeks gestation, uses anticoagulants, or has a bleeding disorder, a low impact mechanism in older adults, or burns with other trauma, and the EMS provider's judgment are also really important factors to consider when deciding on the destination or transport. The American College of Surgeons Committee on Trauma has a list of criteria that defines 4 separate levels of trauma centers ranging from level 1 to level 4. It is important to know which hospitals in your area specialize in specific types of care, such as neurology, burns, pediatric trauma, cardiac care, microsurgery, or hyperbaric therapy. Finally, it is essential to give the trauma center early notice of a patient's arrival. In Oklahoma, we're fortunate that we have the TREC system that you can call into TREC, and they're going to help guide you to the right trauma center, and they're also going to help you notify that trauma center as well. They know what each particular hospital, trauma center, whatever level they are, is capable of and what they can handle at any given point in time. Here's the definitions of those trauma centers if you want to peruse over those and get to know those a little bit. It is helpful to know what those levels mean and what each one of them can handle. So when you're deciding whether to transport a patient by ground, you need to consider a few factors. First, can you get to the right facility in a reasonable amount of time? You also need to consider the extent of the patient's injuries. If you're in a congested area, you'll need to think about whether you can get the patient to a more accessible landing zone for air medical transport. So several factors come into play. Realize that most of the time when we call air medical transport, they'll still have a ground time of 15 to 20 minutes before they lift off and begin transporting the patient. Sometimes in that 15 or 20 minute window, we can make up a lot of ground, driving to the facility. We can be, 30 miles down the road in 20 minutes. So those are important things to consider. May not be a huge determining factor, but if 20 minutes gets you halfway to the trauma center, maybe you don't need air transport. There are several situations when it's appropriate to use air medical services instead of ground. You should consider air transport if it takes a long time to access and extricate a patient who is in a remote or trapped location. This can make ground transport to a trauma center just entirely too slow. Another good reason to use air transport is if the distance to the trauma center is more than 20 to 25 miles away. Because as I mentioned, we can oftentimes be there quicker than the air medical transport can make the turnaround of landing and picking up the patient. Air transport is also the right choice if a patient needs advanced life support care and stabilization, but there's no ALS ground ambulance available within a reasonable amount of time. So sometimes we might put them on a helicopter if we just don't have the advanced level of care in a ground transport unit. In addition to the previously mentioned criteria, you should also consider using air medical transport in traffic conditions or hospital availability will prevent the patient from reaching a trauma center by ground within the ideal time frame. Sometimes major metropolitan areas are going to have congestion issues to where that air transport might be the best option. You should also consider using air medical services if there are multiple patients that will overwhelm the resources at the closest trauma center, and you may need to transport patients to a trauma center a little further away. Some EMS systems may require that patients be taken to the nearest hospital for evaluation and stabilization. This is going to be, oftentimes protocol dependent. You should also consider using air medical services if you're dealing with a multiple casualty incident where there are several patients who will likely overwhelm the resources at the trauma center. You should always follow your local protocols when you're deciding on the best type of transportation. When making that decision, consider if the patient can be transported by ground within a reasonable amount of time. If you need to think about the time it will take for the aircraft to lift off, travel, and land, so that as well as the terrain issues that you're going to have, because this is going to add to that air transport time frame. The military has conducted extensive research on trauma patient care, but it's important to remember that what works well in the military does not always translate really well to the civilian world. A clear example of this was the use of pneumatic anti-shock garments for patients with penetrating wounds in the upper body. These were used for many years during the Vietnam War, but were later found to be harmful to patients in the 1980s. Recent military research has also shown that the dangerous association with tourniquet use and not as serious as believed. It used to be that we didn't use tourniquets on patients because we thought they were harmful. This has led to a significant increase in the use of tourniquets for controlling extremity bleeding in the civilian population. It wasn't all that long ago that we had one of the textbooks we were using, literally in one paragraph it said never use a tourniquet on a patient. The next paragraph it told you how to use a tourniquet on a patient, because the research had evolved so quickly on this and the textbook writers were struggling to keep up. Now the use of tourniquets in the field is very common. In fact, having tourniquets available, for law enforcement, many of them carrying them on their person, as well as, at different locations in schools and public facilities and those kinds of places is pretty common. The military also helped bring the use of TXA to the attention of the civilian trauma systems, and this was really helpful for the control of internal bleeding. So that was another great benefit. So you should only adopt treatments that are supported by evidence for widespread use. Just because we're using it in a military setting doesn't necessarily mean it's always going to translate to the civilian world. But there's been a lot of innovative things that have come from the things that we've learned in the military setting, especially when it comes to trauma, or primarily when it comes to trauma. All right, so that's chapter 30. That is our introduction into trauma and the trauma world. In the following chapters, we're going to talk about specific body systems as it relates to trauma, and we'll dig down deep into those as we get to them. See you back at chapter 31.